Hello, our esteemed viewers. Welcome to yet another edition of the Amplifying Pain Management in Uganda by Palliative Care Association of Uganda, or PICAO. My name is Crispa Andinda, and I am your host tonight. Doctor, it is such an honor to have you on our podcast today. How are you?
I'm very fine. I'm honored to come for this interview today. And if it can contribute to the development of palliative care, I'll be happy to give it. You are welcome.
Okay. Could you please tell us briefly about yourself, your background?
Well, I'm Dr. Amandua Jacinto. I'm now 68 years old. I'm a doctor, a physician by training, and I served in this country as a medical doctor from Yumbe to Arua Hospital. Then I became the Commissioner of Clinical Services in 1999. Yeah, and I retired from public service in 2016. And most of my time, in addition to other things, I was handling the issue of palliative care service in this country. I have had a lot of encounter with the palliative care services, with the patients, with myself. So I'm glad to have this.
What inspired you to specialize in palliative care, and how did your career grow over the years?
Well, I qualified from medical school in 1985. And at that time, there were a lot of problems in this country. And when I was a medical officer, I was posted to Yumbe Hospital. Yumbe Hospital is now Regional Referral Hospital. And I was posted there after the hospital has been closed for 5 years because of the war. So I went there. Of course, things are not very good. And there were a lot of patients who were brought from the Sudan. That was the time when the population in Western Island was returning. There were a number of patients I could not help. Also, I didn't have enough knowledge. First of all, as a doctor, I had just come out of the medical school, and there were a lot of people who returned from the Sudan, and those even who were in West Nile, whom I could not help. So I said, hey, now, what can I do for this? I worked in Yumbe for 3 years. Then I came for my master's in Makerere University. I completed in 1991, and I was posted to Arua Hospital that time as a physician for West Nile, and also as the medical superintendent. That time, Arua Hospital was elevated to a regional hospital, and I also had the mandate of looking after the other hospitals and health centers in the region. During my experience there, we met a lot of challenges. We were young specialists. That time, Dr. Magino was our surgeon for the region now, who is the director of Uganda Heart Institute, and also Dr. Mwambu, and many people. Dr. Fualali, we had a good team, mostly of young people. But there were challenges. There were challenges where you could do something, at the end of the day, you get stuck, especially those patients who had cancer and those who were in pain. And of course, we had a lot of HIV. HIV at that time, even including in West Nile. So I said, now what is this? So one day, there was a patient in the hospital. I was coming with with breast cancer. So I came to Kampala. I wanted to, we discussed with our team what to do. I said, when I go to Kampala, I'm going to ask Dr. Mbide. By that time, Dr. Mbide was the director of the Uganda Cancer Institute. So when I went there, I explained to him, this lady with breast cancer in pain, stage 4, Dr. Magino and the team, they could not do much on the surgical part, and SAP, I had nothing to offer. So when I talked to Dr. Mbide, he told me, young doctor, I'm not going to help you. Because also here in the Cancer Institute, the patient cannot come. But I'm going to send you to somebody. Yeah. So she sent me to Dr. Merriman to go and ask about what can be done. So I went there to Dr. Merriman. I explained. She was very receptive and very kind. I think that time I also met Rose. She was a nurse there. Yeah. So that was my beginning of she talked to me and said what she gave me some medications, of course morphine. I could not get morphine, so I went back. From there I picked up on palliative care.
So, what have been the most significant developments in palliative care that you've witnessed over the years?
Yeah. So I will explain both at the policy level and at the operational level. Yeah, at the policy level, WHO by then was already doing some work. They already developed the pillars of palliative care, which the member countries can adopt, especially focusing on policy issues, availability of medications, especially narcotics for pain management, education, not only of the health workers, but also of the public and the providers and the policy makers on palliative care. Yeah. So WHO had already come with a framework which member states can adapt to do. And also available were some basic medications which could be done, especially access to narcotic drugs. When Dr. Merriman came, one of the first things with the authorization of the minister at that time, Dr. Makumbe, was to begin making morphine in Hospice Africa. That time, we used to just make it on the day of the use. The shelf life was very short. It had to be used within about 1 or 2 weeks. So it will be made in demand. For places like in Arua, in Kabale, in Fort Poto, in Gulu, Karamoja, it will be difficult to access. Yeah. So we had also that challenge of the quality of the morphine in this country, which was actually mixed on the week to be used. It's not like now, where it can stay for 1 month or something. So that also, but it was helping. It was helping with the situation at that time. So that was at the policy level. Now, at the operational level, we had the challenge. First, palliative care was not known, even by our teachers, by our senior doctors. There were, of course, a lot of misconceptions about palliative care, especially about the use of morphine. You see, morphine is a two-edged sword. It can be used for medical purposes. Also, when it gets to the public, it is very dangerous. So the people like the police, the people of the jury, they fear morphine because it is a drug of addiction. But WHO has come out with a good framework where, in addition to controlling the bad effects, the promotion for medical purpose should be done. So I think that was our strength. So we had to have a framework where to educate the population, not only the health workers, but the general public. So we began with all that. Then also establishing palliative care services in the hospitals where the patients are. It's not only the availability of medications, but also getting staff who are dedicated to palliative care. You remember at the beginning, there were very, very few health workers who were knowledgeable in palliative care. Yeah, I think the very first person from this country to do palliative care practically, I think is Madame Rose Chwanuka. Yeah.
What were some of the key challenges you encountered in delivering palliative care, and how did you overcome them?
Well, as I had said earlier, I think the main challenge was that palliative care was not available. It was not there. Yeah. So the first task for me as the desk officer and the Minister of Health and all that the other people was to get palliative care to the patient who needs it and the families who need it. That was a big challenge. With all the things which attend access to services. The main challenge there was from us health workers, especially the senior doctors. They didn't want palliative care to be used. We viewed it as a drug of addiction. Yeah. So we had the resistance from senior people. The other problem which I encountered, especially at policy level, was getting morphine in this country. Importing morphine is not easy. There are a lot of regulations to be done. There are controls from the National Narcotic Control Board. It is a drug under control, so we had to navigate the importation of the morphine in this country so that it could be adequate enough. The other challenge which we faced at the policy level was the issue of education. You know, one of the first things where you can do anything is to educate people. By the time Professor Merriman came, hardly were there any palliative care. Even simple training was not there. So that was a big challenge, which really hindered the growth of palliative care in this country. I think the other big challenge was also the perception from the patients and their families. They thought that if you are referred to palliative care, it is the end. So many people fear, you are sending me to hospice, I'm going to die. Yeah. So it became a big issue to access. There are even the cases I have seen of senior people say, don't put me in palliative care. I will become addicted, even in the last days. So we had those challenges in the early days. I think the other challenge was that especially the policymakers in this country, right from the top, they were not aware of what palliative care is. Yeah. So if you go to talk to them, if you propose anything to Minister of Finance to put some money for palliative care, if you want, they will think this is not necessary. Yeah, I think there are more urgent things to do. So we had to navigate through. Yeah, in addition to making available the things in the hospitals and the health units. But I think over this time, a lot has changed. A lot has changed.
That's good. So how did you overcome some of these things?
Yeah. Now, first of all, I told you that by the time I matured in the system, there were already people who were very supportive. Yeah. I think the ministers I worked with, my director, my senior people in the ministry, the director general, Dr. Professor Maswa, and Dr. Zaramba. After Professor Maswa retired, Dr. Zaramba became the director general, and other people. They were very, very supportive. So we had a very good framework in the Ministry of Health. Yeah. And also the parliament. The parliaments worked. They were very wonderful. There were doctors who were there. Whenever there were palliative care issues, we'll take to them. They will push them through. The ministers will do. So things began shaping in the policy framework. The outcome of this was in the in the health policy strategic plan. For the first time, palliative care was included as a health outcome. I think this was very, very fundamental. Actually, the rest of the world got surprised when they read our policy. The palliative care was there as an outcome measure of our health services, in addition to preventive services, in addition to promotive services, and curative services, and rehabilitation. We now added palliative care, which was a landmark thing to be done into the policy of a government like of Uganda. I think I must thank the people who helped and who accepted. It was a very great move, and I think it made Uganda to stand out as committed to palliative care services. Then the second thing which changed was that education picked up. Hospice Africa, Uganda established a course for nurses. They also began to provide courses for short courses, 1 week courses for health workers, social workers, traditional healers, religious leaders. So those courses became very, very, very vibrant, and many of the health workers, especially the nurses, also took up the healthcare education and palliative care, and our human resource began to expand with time. I think one landmark thing which changed the scenario was in 2004. The Minister of Health, that time it was, I think it's now a general, Jim Muezi. She signed a keynote law for this country. He issued a statutory instrument which allowed the nurses and the clinical officers who were trained in palliative care to prescribe morphine. You see, before that, morphine could only be prescribed by medical doctors, dental surgeons, and veterinary surgeons. Yeah, the other people could not. But also midwives could prescribe morphine for pain in labor, specifically. So for other conditions, the other health workers could not prescribe. So with the restricted prescribers, access became a problem. But when this instrument was issued, it changed the landscape. Though now the nurses who were trained could begin to prescribe. The clinic officers who went, they didn't have to wait for the doctors. It was a very, very big thing for this country. And also with that, the Ministry of Health offered scholarships. There were plenty. And also Hospice Africa had scholarships for training in palliative care. So the number of prescribers went up as by the WHO requirement that if you are to expand, you must have expand the prescribers. So that law changed the landscape in palliative care in Uganda and the whole of Africa, actually the whole world. We were the first country in the world to allow nurses to prescribe, which even countries like America, Europe, and they have not done up to today. Yeah, they have not done. So here, it is something which I think many countries have learned from us, and I'm also proud that the government is still supporting it, and now we have increased prescribers. We now even have palliative care education up to level of masters in palliative care in this country, which actually is helping a lot in the provision of palliative care services. Yeah. The other challenge I mentioned was the one of drugs. Yeah. I told you that when we started, the morphine was in short supply. It was being bought by Hospice Africa, but the Ministry of Health and the government of Square took a step up today that morphine will be provided by government and it will be free. Yeah. So we had issues with the manufacturing it and so on, but we partnered with the Hospice Africa Uganda and also joined medical stores at some stage in the Mulango Hospital. But now, morphine manufacture is fully in Hospice Africa. I think it's still going on, and it is fully paid by government. That helped a lot. Yeah. And the NMS distributes it for the public sector, and the joint medical stairs distributes it for the other health units which you need. This has been a very big help in providing palliative care services. I think what also solved our problem was the presence of palliative care zone of Uganda. Palliative care zone of Uganda has been very instrumental in improving this as our local NGO. You see, Professor had a long vision, Professor Merriman. In addition to providing for education and manufacture, she also promoted national associations, which main aim is to promote palliative care in the country in terms of advocacy, in terms of training, in terms of networking in Uganda, in nationally, and also in the internationally. PICAO was a very big hand for me. Whenever I needed something, we'll partner with them. We formed at the Ministry of Health a country palliative care team, which comprised the Ministry of Health as the hosting organization, and included all the major players in palliative care in this country. It's still going on, including PICAO, Hospice Africa Uganda, the universities, because of the training, the major hospitals, both public and private, hospitals like in Zambia, Lubaga, Mulago Hospital, now even Kirudu and other Nagalama, they took up. So there was a vibrant country palliative care team, which actually drove in terms of coordination, in terms of talking as one voice, and also as a times spreading palliative care, not only within the public unit, but also it helped me a lot to navigate in that. Yes.
So let's talk about how the palliative care perception has changed over the years as you've been working in the field.
Yes. Yeah. Thanks very much. As I said earlier, everything started on scratch. I think there are too many factors which has led to improvement. One, some of the conditions which needed the palliative care, there's now something which can be done. ARVs are present. HIV is no longer as a death warrant as it used to be in the past. There is improvement in access to services, especially to cancer services. And also, as I told earlier, with the conducive services, the ministry has continued to integrate palliative care into the national health service delivery. Yeah. Now, the government has made some very positive steps, even after I've retired. Many things are very good ones. One, there's continued supply of morphine and other medications. There are challenges, but it is there. Number two, government, Ministry of Health and Public Service have moved away ahead to designate palliative care positions, which was not there during our time. Yeah. Now they established palliative care positions, especially in the bigger hospitals, and also now the ministry and the government have moved to move palliative care down, I think up to the level of health center 3 and 4, which is making palliative care to spread out. Now, the other, I think, important thing is also the users. The user of palliative care have contributed. When people see somebody, a user, surviving on palliative care for some time, benefit to the family, and also what the community say, I think it has improved. Then the last thing is actually the associations. PICAO, Palliative Care, African Palliative Care Association, Uganda Cancer Society, the other civil societies who are working in the palliative care, the Ministry of Health, the district local governments. I think all these have contributed to the growth of palliative care in this country. Yeah.
Are there any particular patient experiences that stand out as a highlight, of your work in palliative care?
Yeah. Yeah, as I said, palliative care is not easy. Yeah, both as the patients and the users. Now, I will not mention patients' name, but I will talk of my experiences.
Okay.
Now, one time there was one of our senior people. They had been in and out of hospital, out of the country for treatment. So at the end of the day, we were requested to see. First, there was a pain. The symptoms were not very controlled. So the palliative care team went and assisted this family. The nurses are very good. They control the pain. For the first time, people in that home slept. They slept for the first time. Actually, at the morning, people woke up at around 9, 10. Because there was a lot of relief for everybody. And also I decided I will also talk about myself.
Yes, please.
Yeah.
Yes.
Now, when I was diagnosed with the cancer, everybody got scared. Everybody got scared. We are contemporaries. Most of these senior doctors were in school together. So it was not good, even for me. But what saved me was I said, now, if I break down, it not be good. So those of Rose, I must mention Rose.
Yes.
Rose helped me. Come, Amanda, what's wrong with my brother? What? So in addition to my treatment, I used to party up to today. I still, whenever I have a problem, I still go to the palliative care team to seek for guidance. I'm alive. This is almost 15 years down the road. Yeah, down the road. So I'm actually a living example of both benefit of palliative care at the policy level and also as a patient, as a family. Now, when I walk in public, nobody knows that I'm a cancer survivor, but I'm here. In fact, that time when I was diagnosed with the cancer, they wanted to send me to India. I refused. Yeah, said there are things here in this country which they can use for treating me. Yeah, I refused, and of course I made the doctors uncomfortable. But Dr. Rem worked on me and his team, and the team of palliative care, and I'm here.
How can health workers and the public better advocate for palliative care as an essential part of cancer treatment and any other chronic illness?
Now, as I said, palliative care is everybody's business. For the health workers, we have limitations. Even if we are the best workers, the best trained doctors, the best trained nurses, at the end of the day, medicine has a limit. Yeah. With advances in medicine, in surgery, in radiotherapy, in whatever. And at the end of the day, there are conditions which we cannot treat and cure. We must recognize that as a beginning of everything. The first thing for us health workers is the way which we approach. Number two, it is the community, it is the families. The families are very, very important. A patient with advanced disease cannot help himself or herself. If the family members are not willing to help, they will deny the patient. I've had good experiences where the patient, the relatives say, hey, don't put our patient on the morphine. They refuse. Yeah. If the patient is not able to help himself, he's not like me where I can walk to the hospital. But these bedridden people, if they don't have good carers, access to palliative care will be a challenge. So in our approach to palliative care services, one of the key things is to educate the families. They are part of the care. That is what palliative care stresses. The issue of the patient, the families, then the health workers. They are part of the team which works on that. So if that can be improved, as is being done now, I think a lot will be achieved for this country. And so it is very vital we look at it as team provider, not as an individual.
What are your wishes for the continuity of palliative care in Uganda, especially on cancer pain management? What would you wish to see?
Yeah. Now, thanks very much. I think when I was still in service, I decided I want to make palliative care as available as air in this country, where the person who is in need does not need to strive for it. You see, if you are deprived of air, even for a brief moment, you can see the anguish. Yeah. So the patient out there and the family who does not have access to palliative care visits is like somebody you are suffocating. So my wish was that palliative care should be as available as air in this country. To do that, I think there are a number of wishes which I would like to, which I talked about, and which I even included some aspects in the policy framework at that time. One, government must take increasing interest and funding for palliative care. When in the early years, there was a lot of money from donors. There were volunteers from abroad. There were people who were giving us. But now things have changed. I would have wished, as government is already beginning to do with the drugs and with the health workers, government must be able to provide the money to support palliative care in the public health system, even for the standalone hospices. It's going to be extremely difficult for them to survive if they are doing. There should be an integrated approach to palliative care provision in this country, including providing support to our partners, especially the NGOs, civil society, and the standalone. I think that way we shall be able to move. Yeah. The other wish I would like to have is continuous education and lobbying and advocacy. My experience was that, especially around change of political leadership, change of people in the offices, in the civil service, change of people in the civil society, the new ones need to be educated. So there must be a continuous education by both government and palliative care zone of Uganda, so the people are aware. With the time, people forget. There are new people who have come in board. So there has to be continuous education and the lobbying for palliative care across the board. With that way, I think we shall move forward. Yeah.
How best can the services offered by palliative care be best known to the people in need?
Well, as I said, we must take palliative care nearer the user. This is being achieved through now from the, I'll take the Ministry of Health structure, but I know it is also similar for the NGO hospitals, moving palliative down along the health structure, from the referral hospitals, general hospital, the health centers, to the community, because the structure is already there. Yeah. In the churches, in the local governments, even in these now government programs, this PDM, palliative care can be talked in it. There are these circles which are happening. So there are a lot of government programs in which palliative care can be integrated, first of all talked about and supported. Some of the things which have palliative care can be done by the communities. They're already there. Social structure which care for the sick, which take care of bereavement, and our tradition, they are very rich. Yeah. So if effort can be made to improve on that, it will strengthen palliative care in this country, in the whole of Africa.
So, as we all know that Palliative Care Association of Uganda is celebrating 25 years. This is our final question. What should be specifically celebrated about palliative care in Uganda?
Now, particular to Pikau, I think my biggest for celebration for Pikau in these 25 years will be that they have done a good job. They have opened our eyes. They have opened the eyes of the people in Africa. They have helped the world. It is a model association for advance in palliative care globally. I'm proud to be associated with Pikau. I served on the board for some time, and up to now I'm still a member. They support us even in our little hospice in Arua, New Life Hospice. We work with them. So Pikau has something to celebrate. The second thing which I would like to thank Pikau is for the people expanding, being consistent. In fact, Government Ministry of Health over these years has used Pikau for accreditation, for handling issues of morphine, advocacy, distribution, and also supporting the country palliative care team. Pikau over these years has offered training opportunities, scholarships, not only for the health workers here, but also for the needy. You see, I must say, I think there are even students, orphans of cancer patients who are now doctors, trained helped by hospice, rather Pikau, in their program of Road to Hope. So there is a lot to celebrate in 25 years. Yeah. So I'm also hoping that in the next 25 years, Pikau will be alive and better positioned to help this country and the whole of Africa. That can only be done with our support. With our support, with our advocacy, with our enlightening the need for palliative care in this country, and also being available for any palliative care duties which might. So I would like to congratulate Pikau very much over these 25 years.
This has been such an insightful discussion. So, could you please give us your parting shots or final remarks?
Yeah. Viewers and my daughters, I'd like to thank you very much for giving. The final word I want to say is one, as I've said, palliative care must be as available as air in this country. And palliative care is everybody's business. We all need palliative care as individuals and also as our families, as communities. I would like to thank everybody who has contributed, who made my life very easy, both at Portland and when I was in service. I'd like to wish all Ugandans and all of Africa that we deserve to be pain-free. We desire to live our last days in dignity and to pass on peacefully and leave our communities and the families united. Yeah. Thank you very much.
Thank you so much, Doctor. Thank you so much for allowing us to walk your journey with you. Personally, I feel like I've existed from way back and I know everything now. So thank you for your time.
Thank you.
To our lovely viewers, thank you so much for being consistent with us. Thank you, thank you, thank you. We cannot emphasize that more. And if you would love to be a part of this, please head over to our website. We shall put the link in our description. Yes, thank you so much. Like you've heard, palliative care is everyone's business. So please let us know what you think in the comment section. We love you so much. God bless you. Till next time. Bye.
Bye bye.